So can I ask a question? Sir, all the X-rays we have seen, even in a for a non-robotic surgeon, the exposure is all we need to balance the knee. So where lies the advantage of the robo?
Exactly. So that is the whole essence of actually doing this particular study. What has happened is I feel that the lesser the soft tissue releases what you do, the better the outcomes of the patients. Okay, all the studies which are for kinematic alignment, everything is that whatever native anatomy you should preserve. If you're doing a manual surgery, because with eyeballing, if you consider that you are cutting 1 degree extra of the posterior slope, we are actually using 1.5 mm of tibia posterior we are removing. Even if you are removing the meniscus, you are opening up the gap by 1.2 to 1.3 mm. That is what the thing, which is very difficult to watch with the naked eye. The advantage of robotics it is not, I'm not saying manual surgeries are still the gold standard. Okay, there is no debate between a manual and we don't have to fall in that place where we try to differentiate between a surgeon, between robotic and non-robotic. Advantage you are able to predict the outcome better and you are able to kind of give equal result in all the patients. Okay? You know what is going to happen, you can predict it better. There is no way we should fall in a discussion where we decide between a robotic, non-robotic. That is going to be very difficult. We don't have any papers at all right now. All the papers which are there, they are more in favor of manual surgeries. The outcomes of the surgery, the survivalship, that there is no outcome, there is no debate there is no way we should fall in that debate and saying that this is better. Still, manual surgery is a gold standard. This is a tool which helps you to understand the anatomy better so that we can deliver in a better. That's the only essence of this. The studies of the main thing.
I think we got your point. Question?
So my question is to the previous presentation. There was a limitation of the size of femoral component available in the inventory. So my concern is is it wise to stick to the same implant company or we should explore other options where we can get bigger femur implants?
No. So I'm getting to your question, but it was done with a particular robot, and robots are married to one implant company. So I don't know.
But is robot giving us such a great edge that we will?
But he modified in that he did not use a tune and he used a PFC. So I was about to ask him whether you can do it, cutting with a PFC, because I think it's not only the flexion and extension gap with which the robot helps, it's the surface topography of the implant also, which may be making a difference. I don't have a robot, so I'm not an expert in that. I think so. Maybe from audience, we have 2 big robots. we have Umesh here, we have Hemant here. Maybe they may comment on this. Yeah.
See, practically, you can actually use any robot, use limited, applications of that, and use any implant you like. Okay, you would use distal femur cut, proximal tibial cut, and maybe you will not go for sizing, and other details will not be given to you. But until that point, you could use any, robot if it need be. Practically, you should not be doing it because you want to explore and use all the features available for that robot, for that surgery. It's obviously married for a reason.
Yeah.
There are commercial reasons as well as logistic reasons.
Yeah, but the surface topography of the implant is different.
The important part is you can get the rotation right.
Yeah.
You can mark the rotation, take an anterior sham first, anterior cut, and then put a 4-in-1 jig and you apply the rest.
That's what I do, sir.
But this is all off-label use.
Yes, off-label. It is not.
Off-label use.
No. In case you are in trouble, you can do that.
Yeah. Dr. Vasnik, is it safe in your presentation to replace robot with navigation?
Actually, see, if you should not. So navigation, the soul of robot is actually navigation. Okay, so navigation, one step it is robot. What differences we have in navigation robots are very minimal. Only thing, the outcome which we can see in the graphs and everything what we are getting, it's little bit better. So it is not the right way to say that whether we can replace it. Yes, okay, because most of things are like that only.
I think a question from my side, what is the coefficient of error with robot? Means you are saying 1 degree, 2 degrees. So is it 1 degree, 2 degree only, or does it change? Does it change with cementing and all those things? Means what? Means so, I don't have a robot, so I am totally naive on that.
What happens is, how much you can do with manual also. My question will. So robotic, what happens is, exactly.
I just want to ask you what is the coefficient of error. Suppose it's showing 3 degrees, so it is 3 degrees or it can be plus minus 2 degrees.
So with present situation, what we do is, before we go ahead, so there is no way we have to put extra
If
zigs.
has anybody done a study?
Maybe Dr. Unmesh or maybe, but in my patient what I've seen, there is definitely some differences which is 1 degree, which is not visible to the naked eye because we put a pin which is in the process. I'm not the right person. Maybe people who have done it with extra. Dr. Unmesh might be a better person.
Yeah?
It's precise. There's no error at all. When we check with the, even after implantation, we check. It's absolutely
It's,
precise.
it's very precise. Unless you do a wrong registration, it's very precise. It's very precise.
There are articles published that robotics arm can give a variation of 1 degrees or up to 1 mm. There are articles published.
Yes, sir. The same thing we have published in Indian Journal of Orthopedics.
Okay, so I think we can move ahead.
Yeah,
Jim?
one,
That depends
may,
actually if you're using a saw-based robot or a burr-based robot.
so may I ask one
Yeah,
last,
maybe the last question.
one final
yeah.
question, yeah.
Yeah.
So I have a very basic question. So most of the examples that have been shown in previous talks are, mild or a moderate deformity. When we are talking of gross flexion, gross varus deformity, is there any contraindication of using a robot versus a conventional?
I think after 2,400 cases, there's no contraindication.
Exactly.
More
That's
deformity, better the understanding
Exactly.
of deformity with the robotics.
Exactly.
So,
That's a
okay,
very good
okay.
question.
So I think we'll move ahead. And before we move ahead, to everybody, if anybody wants to read, there's a latest JBJS, there's a systematic review. And the title is Evidence versus Frenzy in Robotic Total Knee Arthroplasty, Systematic Review, Comparing News Media Claims to Randomized Controlled Trial Evidence. I think you should read it, and I think it says that it has a role, but I think everybody should read it and make their own views about it.
Yeah,
So we'll go ahead with the next talk.
Can the chairpersons just conclude that we have discussed so much robot, bone resection, no need for soft tissues? We all understand. So can you just emphasize upon today with robot, navigation and manual, where does the soft tissue balancing and releases stand?
Yeah, so the chairperson
Please.
has to. I am the moderator, I'm not going to conclude.
Say there are two things which robot has brought on the scene. One is alignment, kinematic versus this versus this versus that. That is something, if you believe in that philosophy, you cannot do with eyes. You have to get on with technology. Second thing is soft tissue balancing. Now that robot doesn't tell you soft tissue balancing. That is the way you do it. Now I want to ask the robotic guys, what is limited soft tissue balancing? Where do you stop? For example, zone 1, zone 2. If you want to expose the tibia and remove osteophytes, which are mostly posteromedial on tibia, mostly posteromedial, there is no way you cannot go to zone 2 to get that osteophyte out. So where is your measurement that you will do only limited soft tissue release? I'm not talking about zone 3 release, I'm not talking about that. But just going all the way behind on the medial side, at least in moderate to severe varus deformities, that area is always removed, because I almost removed the osteophyte there. Even reduction osteotomy to balance my knee. So going all the way in zone 2, what difference does it make to the surgery or the balancing?
So there are two things to it. First is soft tissue balancing, and I have shown in my presentations also. We also go to posterior. Okay, we remove all the osteophytes. Okay, so that is the principle what we all have been follows over the ages. We are not talking about. We are going to remove all the osteophytes, whichever is posterior. But if you see over the time, when I used to release completely on the posterior middle side, going behind and release, that has completely stopped. I think Dr. Unmesh and Dr. who are doing robotic. Dr. Unmesh, what's your call on releases
I think
in
we can
soft?
discuss it over coffee. We are getting late. To conclude, I'll conclude it. I think robot is a great tool to become more accurate, and it's definitely needed if you want to try alternate alignment philosophy.
I have talked for that. I have talked.
Yeah, so I think he's going to talk. So we'll move to the next talk by Dr. Sanjay Yadav on how to do it the poor man's way, a varus knee.
I must say, being under all these robotic surgeons is making me feel increasingly human.
Yeah. So thank you. I feel privileged to be here, and I was senior resident at All India Institute, so it is great to present in front of Professor Vijay sir. So now, for the first two talks were for those so-called 10%, as per Maheshwari sir, those who have robots, so those who don't have robots, and many of us. So this is for the rest of the 85 to 90%. So we go it simple. Varus is the most common deformity. So TKR in varus knee, I'll just rush through because since in the teaching students we have prepared it like that, but I'll finish in time. So I thank all my institutions where I have learned all the pros and cons. So it is the most common angular deformity, hence one should know about it. In varus knee, the extra-articular deformity is femoral bowing or varus proximal tibia. Constitutional varus is like less up to 3 degrees, and there's say in some state correction of varus knee may also correct the valgus hindfoot. So these are some of the classifications. So in well-aligned knees, it is up to 0 to 3%. So now the robot keeps you within these to 0 to 3%, 1%, that's a different take. And again, in Pavizzi classification, we have intra-articular, metaphyseal or diaphyseal as per the management. So priority planning, long leg films, advanced deformities can have a concave shaped tibial plateau, which is called as pagoda shaped, and the importance is that it can lead to a difficult tibial dislocation. So valgus correction angle, we usually keep at 5 to 10 degrees, going by very, very basic standard procedure. Knee evaluation, you have to assess the recurvatum of flexural deformities. Flexural deformity plus varus knee is then in these cases you have to release the PCL and you have to proceed for the sacrificing implant, and the gait pattern should be assessed. That differentiates between a fixed varus and varus plus thrust, where you need to go for or think of the constraint requirement in your mental background. So varus knees plus ACL, Noyes et al. Has classified or say 3 types of single, double or a triple varus. Varus knee with ACL deficiency can develop over time a posterior lateral soft tissue deficiency which leads to the thrust, and it may need some kind of a constraint. And it is very mandatory to evaluate the reducibility of the deformity. Implant selection, mild varus, standard CR or PS can be done. Normally reducible, no need of constraint. Varus plus flexion contracture, PCL is a part of the deformity, so should be released and then proceed for the posterior stabilize. Increased revision rate leads to decreased ROM and survivorship if a CR implant is used in such cases as compared to PS. And condylar constraint, normally they are not necessary in varus deformities. Semi-constrained implants, when you have multi-ligament injuries previously associated, or in severe flexion deformity, if it cannot be balanced, then you may need to have these semi-constrained implants also. Extra-articular deformities more than 20 to 30 degrees, you need to correct it osteotomy or extension, or increase the level of constraint, then mid-level constraint bearings they are coming up, so we will stick to the basic. So surgical technique, all standard, middle plateau exposed to posterior midline, and then Ransel maneuver, you flex the tibia and put an external rotation, and then release for the first 2 centimeters. Soft tissue balancing, we go with the osteophytes first from the plateau and the condyle because the bow stringing effect on the ligaments. Then there is a deep MCL with the Cobb's elevator in a figure of 4 position, that is with foot external rotation. Then you remove the posterior osteophyte and additional releases as per requirements, but one should keep in mind that those are the last resorts. So this is a treatment algorithm which we have just discussed, leading to final mediolateral balance in varus knees. Bone cuts, so I go with the standard tibial proximal cut, perpendicular to the perpendicular long axis. You maintain a platform and then you build up your rest of the things over that. So medial plateau, if large bone defect, it is possible to increase the bone cut. You shift and resect laterally. For every 2 mm lateral shift, 1 degree can be corrected, as per Mullaji et al. Femoral cut, standard, keep it as 5 to 7 degrees. Uncontained defects, they are addressed using the same procedure as used in revision. So we get deformities late, so less than 5 mm only cement. When it is bigger, you can cement with screws and then additional long stem and augments. Or you can use the bone graft from the cut part. So femoral resection, you can reduce it less than 8 mm. If you find that it is a severe deformity, tibial subluxation, severe mediolateral laxity and recurvatum, then it is safer to actually start with the 6 mm and then as per requirement, you can actually proceed. So this is a shift resect, which we already discussed. Downsize the plate and lateralize. Then sliding medial MCL osteotomy, last resort for recalcitrant deformities. In a study by Mullaji et al., he has stated that if we do a sliding medial MCL osteotomy, then actually it reduces the need of the constrained implants. It can be used for both flexion and extension contracture. You shift distally, manages the extension. You shift it posterior, manages flexion. So some of the case examples now. So this is a 68-year-old male. These are all the x-rays, so we did the left side, see very gross deformities even on the x-rays. This was done probably when I joined maybe 6 or 7 years ago. So these are all the concerns in these fractures, in these cases, which should be kept in mind. So with our experience, or I have seen some of the bilateral cases going, so we always do 1 by 1. And you always get long films to see whether old hip fracture nailing can be there. So these are all the procedures. You see the degree of the bone defect in such cases. So this was the post-operative X-ray, and we could manage that with a screw and a long tibial stem. So these are all the clinical photographs we do one by one. This is another case example where again the defect was managed with supported with the screw cement and the long stem support to share the stress. This is another example where the screw was not used, so we could manage with a standard tibial base plate. This is another example again where the screw was needed. We have shifted the tibia laterally and then removed the medial tibial condyle and supported with a long stem. So this is again another example where there was a stress fracture. This is another important chronic deformities can lead to stress fractures. So all the more importance of long films. Patient may complain of pain which is distal to the joint line. So one should be very watchful. They can be subtle also. Yeah, so just 2 more slides. So this is again another case example with the severe varus with stress fractures. There is some remodeling going on because the patient still kept on lingering. So this is I bring the final case example, and then again managed with screw and long stem. This is another one with the defect. So to conclude, it is the most common deformity. One should know how to manage it. Adequate balancing and deformity correction are mandatory. The alignment correction, soft tissue balancing is actually a stepwise approach. First take care of the osteophytes and then manage the soft tissues. TCAR in varus knee is a highly effective procedure, 10 years outcome reaching more than 90% if adequate soft tissue balancing, stability, alignment, and fixation are obtained. So with this I conclude. Thank you, sir.
Thank you very much. Now next we'll have 2 talks on valgus, and then Dr. Unmesh Mahajan has to leave early, so he's going to throw some light on robot in TKR. So that will be the last talk. Necessity. Yeah, necessity or no. So next 2 talks, next Dr. Hemant Wakankar is going to combine his talks on balancing valgus in OA.
Yeah, thank you. I'm going to combine both my talks here. At the outset, let me thank CAWNPORE Arthroplasty course organizers for this kind of opportunity to talk to you. I'm going to present to you the spectrum of sorry, that's the previous talk. We need to get rid of that. I'm going to present to you 2 cases here, one, giving you the complete spectrum of valgus that you can see. One is osteoarthritic valgus knee, and second is rheumatoid valgus with severe osteoporosis. Right, can you get my talk on, please? Okay. Lovely, there you go. So in first 1 minute, I'm just quickly going to run through what we are dealing with. Valgus, as you know, is a different ball game. I'm going to deal with all these aspects here. Approach, the cuts, the balancing, the rotation of the components, and how you deal with flexion. Let's quickly talk about pathological anatomy that you're talking about. We are talking about tight lateral structures that includes IT band, lateral and posterolateral capsule, lateral collateral ligament, and popliteus. Along with that, we are talking about medial stretch out of the ligaments and obviously the bony deformity. Or bony anatomy, you will have deficient lateral femoral condyle, some amount of tibial bone loss, and some amount of tibial tibia valga, along with extorsion of the tibia. This is the case that I'm showing you today. It's the right knee that we are dealing with. This is the mechanical axis of this patient. This is the osteoarthritic lateral compartment arthritis. And I break down the mechanical axis into 3 components. One is the femoral component, and we talk about the anatomical axis of femur and the mechanical axis of the femur and angle. The angle that we use for distal femoral cut. The tibia is cut perpendicular to the long axis, and then intra-articular balance is going to give you the overall straight mechanical axis. Now this particular knee, I've shown you the preoperative scanogram here. Now this was shot using a GoPro in my helmet, so sorry about the movement. There's hardly any flexion deformity here, but valgus is almost, almost 50% correctable. Now, whenever I do a valgus knee, I decide whether I'm going to have problems with the patellar tracking and take a mid-vastus approach whenever I expect some. My left index finger is on the top upper pole of patella, and I'm taking a mid-vastus approach here. So I'm going to split the fibers of the vastus medialis and get the exposure here. So then I will have my entry point on the white sides line, and with that I'm going to, if you looked at the scanogram, that angle was 7 degrees. It's not necessary that every time you have to take 4 or 5 degrees for a valgus knee. I suck out the medullary canal, lavage the canal and suck it out, and here I'm using Zimmer LPS, and I put my valgus angle here at 5 or 6 degrees. And as expected, there is going to be a gap on the lateral side on the femoral condyle, so it's because of that is what is giving you the valgus deformity in the first place. So I put my pins in and 0, and then see how much bone I'm resecting. So long as I'm resecting very small amount of bone from the lateral condyle, I'm okay with that. If it is not touching the lateral condyle, then I have problems. But here I measured the medial condyle, that's about 8 millimeters. Now here is a long, the tibial jig. I'm using extra osseous alignment, and get my stylus on the medial side. I take medial side as a reference and usually take about 4 millimeters of the medial tibial plateau. That is a typical what I use for valgus. I can adjust this up and down by millimeter if I need to. And here I've used a 2 millimeter stylus and got the jig down by 2 millimeters. So this is the way I take my tibial cut, and as you can see, very little bone has come off the anterolateral side of the tibial side. And when I put my distractor, you can see that the gap is trapezoidal, the lateral side is tight. You can see the popliteus tendon there. Now the 4 structures that I talked about earlier, I run my finger on the posterior lateral side and judge what is tight. And I'm at the moment doing the releases of the IT band. I'm going to do pie crusting and release the posterolateral capsule, and see how much correction I get with release of these 2 structures alone. Now this is the 10 millimeter spacer block that I put in, but as you can see, medial side is still slightly lax. So lateral side is opened up to an extent, but medial side is still lax. I still need to release more on the lateral side in order to get the equal balance. So I again run my finger here. I can feel that lateral collateral ligament is still tight. I'll just do a couple of punctures into the lateral collateral ligament, and even the IT band, if there are any tight bands, that I can still do the pie crusting off. Then I'll try again the 10 millimeter block first. That shows me that even the lateral side has opened up a little bit more, and then I'm going to try the thicker poly. So as you can see, the lateral side is opening up slightly more. Now I'm putting a 12 millimeter block in and make sure that it is well balanced in full extension. So once I do that, this is 12 block in, and this is well balanced both in flexion and extension. Next, typically for osteoarthritic knee, I'm going to mark my epicondylar axis. I palpate both epicondyles and mark this line, and I'm putting an osteodome between the posterior arm of this jig and the lateral femoral condyle. That actually accounts for the hypoplastic lateral femoral condyle, and that does 2 things as well. That gets the femoral size up as well. And when I put my pins in, I make sure that that is parallel to my epicondylar axis. And with that, I will cut my posterior condyle, maybe get the balance in here. If I'm happy, then I'm going to proceed with finishing all my femoral cuts here. And once I do that, I will get my again spacer block in and make sure that it is well balanced. And when that has happened, the surgery is practically over at this point. It's just a matter of finishing the cuts and cementing and going ahead with implantation and trial. So I will, I think with this, I will move on to my next, this is the postoperative scanogram of the same patient. The deformity is fully corrected, and this is the Zimmer LPS posterior stabilized knee. Now next is a completely different spectrum of valgus knee. This is the patient who was bedridden for 2 years with bad hips and knees, severe porosis, valgus and FFD. This is the hip of this patient. The left hip was tackled because that was the most symptomatic to start with. My colleague did this with augments, and it was quite a challenging hip. But after that, about 3 months later, I am coming to do these knees now. I am going to be showing you right knee that I have done, severely porotic knee. As you can see, the patient has a fixed flexion deformity and severe porosis. And that's the video that I am going to show you here. Now it's a different ball game for the simple reason there is a huge chance of having intra-articular fractures, either of the epicondyles or even the condyles. This is about 40-45 degrees of flexion deformity that the patient has, and that is the valgus you have. So I am taking a routine medial parapatellar approach here. After the arthrotomy, it's important that you excise all the fibrotic capsule and the synovium, or the remnants of the burnt out disease that you have. It is very soft, so you can just walk the drill in and intermedullary. So I'm hardly putting any pressure. It's so soft and porotic. So I'm going to again lavage the canal and suck it out with that prevents the possibility of fat embolism. Now again I'm taking, using this jig, I'm putting it in 5 degrees, and here I've decided that with such big deformity, even after the posterior soft tissue releases, I'm going to need extra distal femoral cut. So I'm actually starting with 2 millimeter plus femoral cut here. And after I take my cuts, I'm going to measure my medial femoral condyle, that is about 11 millimeters. The lateral condyle measures to about 7 millimeters. So that is what you would expect in a typical valgus knee. As you can see, it's extremely porotic. I still mark out these pinholes because if I need to revise those and come back and maybe take extra cuts, I can do that. Now this step is extremely, has to be done very carefully, provided because the tibia can crush in as well as the femur. So you need to be very careful when you put that posterior spike in. And here again, I'm taking medial side as a reference. I'm going to, this stylus, this is the max PCK that I'm here. I've decided here that I'm going to use intramedullary stems and I need a constrained knee here. So I'm putting the stylus at 5 millimeters and just aiming to cut 4 to 5 millimeters from the medial tibial plateau. And as you can see, it is just tending to crumble, and on measuring, it's just measuring about 3 or 4 millimeters on the medial side. So excising the PCL remnant here, and if you see, this is a very important, in 90 degrees flexion, I can see that the gap is much wider in flexion. And remember, there was 45 degrees flexion deformity here, so I'm going to be much tighter in extension. So here, although the femoral sizing was showing A, I'm going to size B in order to tighten my flexion space. So this is size B I have gone for. I have upsized the femoral component. And I have put my medial homens and protecting it for any damage to the MCL. And here I have upsized the femoral component, and then I am going to check my gaps. What it looks like. Very little bone comes off because it's a bicondylar wear. And I'm releasing my posterior capsule now. I use this curved osteotome on the back of the femur and run my cautery on the posterior capsule and release it all the way, not only in the center, but both posteromedially and posterolaterally as well. So I run this cautery on the posterior side, and then I take a sharp curved osteotome and actually release physically from the posterior cortex of the femur, all the capsule that is there. And once I do that, then here I have decided to use a constrained knee, so I perceived there was some tightness on the lateral side. The trouble is, if you do not do this, then you can actually end up having fractures of the lateral epicondyles. So I've just done some release on the lateral side as well, and as you can see, this is balanced here. And here I have 11 millimeter spacer block going into flexion space. Now many times you have to actually do the visual inspection rather than putting these blocks in, because the bones are porotic, they tend to crush in when you put these blocks in. So one has to be careful while putting these blocks in. I'm doing some release on the IT band on the lateral side. Now next, because I've decided to use intramedullary stems here, I'm going to be preparing both tibia and femur to accept those stems. Now here's a size 1 tibial base plate being prepared. The rotation has to be taken care of at this point of time. I'm marking my rotation here. And after I prepare my, after the broaching, I'm going to using sequentially the reamers. And this is finally, I'm using a 100 millimeter stem. And that is going to be attached to a 30 millimeters of tibial base plate. So total ream depth is 130 millimeters. This I have gone to 13.5 millimeters of reaming, so that's 13.5 stem, 1300 into 13.5 millimeter stem being attached to the tibial component. And that is pretty thick because it's extremely porotic and wide medullary canal. That's why you have to go all the way to 13, otherwise it's very rare to use 13 stem in the tibial side. Similarly, on the femoral side, I'm preparing to accept the PCK femoral component, and here I have the final reamer is with 15 millimeters. And it is hand reaming, mind you. You have to really feel that you're biting the endosteum and getting the tight fit into the canal. Make sure that obviously you don't perforate the cortex. And this is the 1500 by 15 millimeters femoral stem being attached to the B size femur, and that's a trial PS component. That's a PS trial. It is not a constrained trial. I'm going to try this, how it feels. It actually gets my knee to complete full extension and good balance in flexion as well. So I've decided to go ahead and cementation of these. Then obviously I will do the pericapsular infiltration here using the cocktail that I use. We talked about this earlier. And after that, I'm going to be lavaging this. Obviously patella is obviously worn out, but still extremely porotic. So I'm not going to be doing the patella, resurfacing the patella at all. I do the hemostasis before I start cementing posteriorly. And even the pulse lavage, if you put it in high speed settings, it can damage the bone, and it can, with severe porosis, even the cancellous bone flakes can come out with high speed of pulse lavage. So you got to be careful with that as well. Because I don't want any cement to go into the diaphysis or the medullary canal, so I'm going to be metavessel, cementing only metaphysis here. So I put the component in halfway and then push the cement by the side into the metaphysis so that I have only metavessel cementing here. So after I do that, I'll get this completely seated to the depth. Same thing on the femoral side as well. I want only metavessel cementing, so I don't want any cement to be dragged inside the canal with the femoral component stem. And here you can see that this is only, again, I'll get the component partially in and then push the cement by the side of the stem into the metavessel area so that I get better purchase in that here. So that is the way I do it. This actually gives you good metavessel fixation for both femoral and tibial side. And then I will get my final poly in. Now here final poly also has a locking screw, and I don't know if you've used this system, but this PCK locking screw sometimes can be tricky. So just getting this in, and it's a matter of banging it in and getting the final screw in. So that is in the enclosure. So to summarize, I think the challenges in valgus knee can be, you have to break down this surgery into various different areas. The distal femoral cut is going to be based on the long leg scanogram. Tibia is in the long axis, but I reference the medial tibial plateau. Balancing first in extension and that achieved with graduated soft tissue releases. Graduated in balance in flexion, you have to look at the epicondylar axis. Patellar tracking obviously depends on both rotation of femoral and tibial components, so that has to be taken care of. And for severe porosis, you should consider using IM rods, with constrained disease. I burned my fingers in the early stages of my career, and really you need to use, your threshold has to be pretty low for using intramedullary stems. Thank you.
Great presentation.
Delegates who have registered for the robot workshop, please contact on the registration counter outside.